All right. Good morning and welcome to the University Hospital's Health Services Research Center Distinguished Speaker Series. My name is Sarah Ronis. I am a Child Health Services researcher in the Department of Pediatrics, and I serve as the director of the UH Rainbow Center for Child Health and Policy. It is my great privilege to moderate today's session. Before I introduce today's distinguished speaker, I have a few housekeeping reminders to share. First, this webinar is being recorded and will be available to view in the future from the UH Research and Education Institute website. Second, we ask that you mute your microphones throughout the presentation. If you need technical assistance, please message either Nicole Bollinger or Abigail Zona, who are joining us from the Research and Education team. You should be able to find them in the chat. If you have questions for our speaker, please enter them into the Q&A section. By default, all questions can be seen by attendees, but you have the option to submit them anonymously if you prefer. Finally, I just want to review our agenda for this morning. We'll have about 30 minutes of comments from Professor Browne, followed by a Q&A session that will conclude at approximately 11:40 Eastern Standard Time. At that point, we'll wrap up the public portion of the session, and we do ask those who were invited to the meet and greet to please remain online following the Q&A. So with those housekeeping notes out of the way, I am delighted to introduce Professor John Browne. Professor Browne is a health services researcher in the School of Public Health at University College Cork, Ireland. His research portfolio focuses on ways to improve the quality and safety of healthcare. He completed his PhD at Trinity College Dublin. He then worked at the Health Services Research Unit of the London School of Hygiene and Tropical Medicine from 1998 to 2008, where he oversaw the development of the National Health Service Patient Reported Outcome Measures, or PROMS program, as well as the Acute Care Clinical Guidelines program for the National Institute for Clinical Excellence. He also served as principal investigator on the study of the implementation of reconfiguration on urgent and emergency care networks funded by the Health Research Board, and he currently serves as a senior editor at the journal BMG Quality and Safety. Professor Browne, we're delighted to have you here with us today. The virtual floor is yours.
Thank you very much, Sarah. So I just moved to slideshow, and hopefully everybody can see that okay and can hear me okay, and I will begin. So first of all, thank you very much. I'm honored to have been invited to give this talk. I give this kind of talk to different audiences around the world. And I hope you learned something about this important topic around emergency care centralization. So, as Sarah said, my name is John Browne. I'm a professor of health services research here at University College Cork, which is the second largest city in the Republic of Ireland. And I'm also a senior editor at BMJ, the Quality and Safety wing of the British Medical Journal. So in my talk, I will first look at the policy background in this area. So where did centralization come from? Why do people think it's a good idea? And then review the evidence on the whole population impact of urgent or emergency care centralization. Now, why am I talking about whole populations as opposed to single conditions? And many of you will have heard about the evidence in this area in relation to single conditions like stroke or STEMI or major trauma. I'm taking it because centralization impacts the whole patient population who have emergency conditions and use emergency departments or whatever you want to call them, accident and emergency rooms and so on. So if you close an emergency room, if you close an emergency department, you can't just focus on the 2 or 3% of patients who might benefit from that. You should be taking into account the whole group of people who use that facility and not just blithely assume that, well, they'll all, the rest of them will find their way somewhere. I'm only going to talk about urgent and emergency care, so my talk will not cover planned care domains such as oncology, where there is strong evidence in favor of centralization. And I'll then move on to some reflections on the quality of the evidence base, so how good are the very small number of studies, before I talk about the framing of the evidence base. So, what kinds of research questions are we asking here? And also the mechanisms by which centralization might be harmful. And then I'll finish with some insights into the broader influences on policy in this area, which I think are often hidden from public view, and add some reflections on the role of values. And please note that some of my slides are taken from a presentation given by Dr. Marianne Flostrup from Denmark. That can be found at the link below. So starting off with the policy background, many of you will be aware that emergency care systems have been reconfigured to varying degrees across different countries and regions, including the United States from the 1990s onwards. What do I mean by reconfiguration? So it's occasionally very ambitious and planned with the goal of having whole system integration of care pathways for large geographical areas, including bypass protocols for stroke, STEMI, major trauma, the introduction of minor injury units or other types of facility for people who don't need high acuity care, and then maybe another set of pathways for frail older people. And as you're all aware, that's really the growing source of pressure on acute facilities. But in my experience, these really planned, comprehensive reconfigurations are relatively rare. And the main thing that we see in reconfiguration is the closure of smaller facilities, especially in rural areas and peripheral areas. And there's growing awareness that that has created significant access barriers for older, poorer and rural populations, and is contributing to a general dissatisfaction with health policy decisions, and part of a larger disconnect between what are commonly referred to as urban elites, like decision makers, and whatever the opposite of an urban elite might be. So as with many of the terms in this area, people throw around terms like urban elite, but it's not quite clear what that means. And why are we doing this? Well, the main reason that people put forward, or policymakers and decision makers put forward, comes from the claim that smaller hospitals are either less safe or less efficient than larger units. Now, why they're less safe opens up another can of worms, which is also disputed. So some people say that volume is a good in itself, and then there are other issues around staffing and how it's become harder and harder to staff these smaller facilities because of the growth of subspecialization and the relatively unattractive nature of generalist hospital careers. And as you can see, during the recent election in the United States, this became a big hot political potato. So many of you will be familiar with the growing concern for the sustainability of rural hospitals in the United States. And here you can see Rachel Werner from UPenn discussing the fact that nearly 200 rural hospitals have closed in the US in the last 20 years, and many more are in danger. And that has started to become a big political hot potato. And you can see how the unsuccessful Harris-Walz campaign in last year's election were clearly aware of this, and they needed to show that they were aware and doing something about it. So you can see here the specific commitment to protecting rural hospitals. And then if you look through the Trump campaign policy documents, it's hard to see anything specific about rural healthcare. And it's not easy to imagine in a world where the gap between campaign rhetoric and concrete action starts to become apparent quite quickly. This is a really interesting article I found by Thomas Campanella from Baldwin Wallace University, which points out that rural America massively supported Donald Trump, and now is probably expecting something in return in relation to health policy and the equity gaps that have opened up between urban and rural populations, and the access gaps that have also opened up. Whether that actually translates to concrete actions in the next administration, let's be charitable. So what is the evidence about the impact of emergency care centralization? So I'm going to start with this Danish paper, which we published in the journal. I consider this to be the best paper that has been published on this subject so far. So when I present evidence from different countries, I'll try and describe the context of those countries, because what we're talking about here is not just what's going on in the hospital. We're talking about the population and the geography it serves. And clearly, the decisions you take about reconfiguring 2 or 3 hospitals in a very large urban center, which are only a mile apart, are very different from, let's say, the decisions you would make in Northern Ontario in Canada, where you could be talking about thousands of miles apart. Here you see the population distribution of Denmark, which is clearly skewed to the east of the country. So the darker red sections mean more people. And that's where you have the big cities of Copenhagen and Aarhus. And then you see the western and southern parts of the country are much less densely populated. And Denmark is not actually a bad comparison for Ohio in terms of population density. So here you see the Ohio population distribution. Ohio has a density of around 112 people per square kilometer compared to 137 people for Denmark. So not massively different. And here you can see the distinctive diagonal settlement pattern that you have in Ohio from Cleveland through Columbus to Cincinnati, with Toledo up here. And then obviously these much less densely populated areas in Western Ohio and especially in Southeastern Ohio. So what did they do in Denmark? So in 2007, the Danish National Healthcare Authority proposed a reconfiguration plan for emergency care. And over the past 15 years, they've gone ahead and implemented it. It involves the following elements. So fewer emergency hospitals, or hospitals that accept emergency admissions through mergers, the closing of smaller hospitals, building a small number of newer hospitals, the centralization of specialized treatment, such as for major trauma, the presence of relevant medical specialists at all time, 24/7, and mandatory referral to the emergency department from GPs or a dispatch center. So that means you can't just turn up to the emergency department without having come through a primary care facility or obviously by ambulance. The reconfiguration means the number of acute hospitals in Denmark will go from 44 in 2007 to 21. So a very dramatic reduction in the number of hospitals that they have. And obviously that will mean longer travel distances for rural patients. And here you see, this is Denmark in 2005 and 2016 in terms of the hospitals. And you can see the yellow dots represent hospitals with full acute services, including emergency departments. So in this southern region, for example, you can see in 2005, they had 1, 2, 3, 4 full acute hospitals, whereas in 2016, they only had 1. And then these other hospitals, which are not providing acute care. So, a very important and big dramatic change. Now, obviously, these Scandinavian countries have incredible data sets because they've got a national health service, and they've got unique patient identifiers for everything that's happening outside the hospitals and everything that's happening within the hospitals, and they're able to connect them to outcome data such as mortality data. So if you wanted to find out if something like the reconfiguration they did in Denmark is either working and having benefits or is harmful and is killing more people, then you would do an interrupted time series, and you could do that in a controlled or an uncontrolled fashion. But let's just say here we're only going to do an interrupted time series because it's affecting the whole country and there isn't any relevant control other than the pre-trend. So why do we talk about trends? Obviously, we talk about trends because in this area, things are always getting better. So I'm sure many of you will be familiar with the idea that mortality from, for example, cardiovascular conditions is dropping significantly across the developed world, at least, and has been doing so. Survival from stroke and heart attacks has been increasing for many years in these countries, to do with improvements in lifestyle, but also to do with better technology. So unless you're accounting for trend, then you can't really figure out what was the impact of an intervention. So the idea here is to detect a slope change. Ideally, reconfiguration would bend the slope downwards. So that's what we're looking for, obviously, because mortality is a bad thing and we want less of it. And arguably, it would also be bad news if this is what we see, just a continuation of the pre-trend, because then the argument will be, well, why did you do it then? Because nothing seems to have changed, that we're just on the same trajectory that we were before. And obviously, this would be a disaster where you have interrupted a previous supply of good news. And unfortunately, this is what happened. So you can see for in-hospital mortality, there was no significant change in the existing trend. And for 30-day mortality, there was actually an uptick in the slope. So it's not a good result. And remember, the main reason centralization is proposed is to make the system safer and to improve patient outcome. That's why it's been sold. It's been sold not on efficiency grounds in these national health services. It's being sold on safety and quality grounds. And also, let's take a second to reflect on the baseline trend. So before they did all this stuff, you have a pre-trend where mortality is decreasing by 5.5% per year, 3.5% per year for overall 30-day mortality. Now, in that environment, why are you doing anything? Like, what problem are you trying to solve? And I think that's a question which is often not asked before these changes are made. And here's an Irish paper which my team published in 2018 in BMC Health Services Research. I won't pretend that it's as good as the Danish paper. The Danish paper has, it's a census. It has millions of patients. It has every patient over that period who were treated in every hospital in Denmark. Now we were able to look at every patient over the period in Ireland, because in Ireland we also underwent a reconfiguration, which I'll discuss. But the joining of service data and outcome data wasn't as complete or as accurate as you see in Denmark. So you see what Ireland looks like. So here, again, red means more densely populated, and green means more highly rural and remote areas. So here you can see Dublin, and here you can see Cork, where I am, and this is the Western Seaboard. If you've ever been to Ireland, you'll know that this is mountainous and much more sparsely populated than the south and the east of the country. And there's a mountain range that also goes up in this area as well. And for scale purposes, you can see a small rural hospital in Bantry that lost its emergency department about 10 years ago. And now patients in this area have to drive 82 kilometers to Cork, which is on terrible roads, which means about a 90-minute driving time. And here you can see the current location of emergency departments in the red dots, and the black dots show you the 10 emergency departments that were downgraded to local injury units and which are open on a limited basis. And that happened over the period 2002 to 2017. In fact, those 10 emergency departments were nearly all closed over the period 2009 to 2013. So our team performed a similar analysis to the Danish study, and here you can see the overall trend in case fatality ratios for a basket of 16 emergency conditions, including stroke, heart attack, and major trauma, and a range of other things for which you would expect an emergency department to be good at saving lives. The overall trend is very positive from start to finish. It's going down. Again, very good news. You see this across the developed world. However, joint point analysis revealed a significant break in the linear trend around about here. Before 2007, case fatality had been falling by 3.54% a year, whereas after 2007, which is when the reconfiguration program really started, the rate was only 1.2% a year. And again, it's very interesting to ask why. Where was the policy emphasis? When we ask, our students to write a research protocol, the first thing we ask them to do is write a problem statement. What problem are you trying to solve? So it's not quite clear here what problem people were trying to solve. Now, just for completeness, I'm going to show you two smaller UK studies that also looked at whole population impacts of centralization. In the first study, the impact of downgrading 5 emergency departments was found to have no statistically reliable evidence of a change in mortality. So again, no benefits. And in the second study, the consolidation of 3 acute hospitals in Northern England was linked to a small but significant improvement in mortality. So this is the only good news story, but it's important to understand that the 3 hospitals here are basically all 3 of them were in very close proximity to each other in an urban environment. And really, that's it. So nearly everything else you'll see in this area has to do with single conditions. And the literature is full of single condition studies, looking at major trauma, looking at heart attacks, looking at stroke, looking at abdominal aortic aneurysm. and maybe and one or two other areas around acute surgery. So in summary, the evidence base does not support centralization if what you're looking at is the full population of patients that use the facilities that are being either closed or downgraded. So there's no evidence from the small number of whole country evaluations that have been completed that reconfiguration has improved mortality. And the limited mortality evidence we have is not supportive of emergency care centralization. The evidence base is weak. We have few studies, mostly weak designs other than the Danish study. Obviously very hard to map from context to context, but that's, to me, that again is another weakness for the argument, because you will hear sometimes people say, well, we all know volume matters, and we all know that bigger is better. But obviously that isn't true from context to context because of the context-specific issues around geography. So in Ireland, we have 72 people per kilometre squared. Ohio, 112, Denmark, 137. If I showed you Canada or Australia, obviously the numbers would be wildly different. And we have remarkably little evidence about balancing impact. So what is the impact on equity in terms of income, poorer groups, older people, and then obviously geography, which is now the big hot political issue around urban and rural. We don't have that many studies which examine the timeliness of care in detail. Sometimes I will see these strange papers that say, well, it doesn't really matter where an urgent or emergency care facility is. All that matters is that they've got the staff and they've got the facilities and they've got the volume. That seems like a very odd argument to me. Why do ambulances go fast? Why do they have flashing lights? Obviously, because you want to get there as quickly as possible. And the further away you are from the place you're trying to get, the longer it's going to take. I mean, that doesn't seem like rocket science. We never hear anything about environment. It's the policymakers in this area seem to give themselves a get out of jail free card in terms of all the extra cars on the road. And it's not just the ambulances, it's not just the patients. When someone is admitted after some emergency event, carers are spending hundreds of extra miles and kilometers on the road, up and down all day long to visit their relatives. We don't really know much about the impact on staffing or overcrowding and overspill at hub hospitals. And we know very little about the efficiency of mitigation measures, for example, converting smaller emergency departments to minor injury or acute assessment units. And we know very little about patient or carer experience either, or disrupted relationships with local providers, like the knowledge that smaller facilities have of primary care providers, rehab facilities, residential care. So why might it not work? So I can think of a number of reasons. So first of all, it stresses the system as a whole, which leads to overspill crowding in hub hospitals. And this will happen if planners do not account for the underlying growth in need in aging populations and allocate resources appropriately. Second, centralization can harm condition groups where centralized care is not superior, especially difficult presentations. And this, if you look at clinical epidemiology in emergency care, this is the big growth area. We're not seeing a tsunami of more strokes or more major traumas or more heart attacks. We're seeing a tsunami of older, poorer people with complex mental, physical, and social needs. I'll give you an example. A frail 80-year-old woman falls at home because of antidepressant-associated hyponatremia. Her husband observes a convulsion, possible head injury, possible broken leg, which turns out to be a knee fracture, which is not operable. Now, you've got the decision. Should you transport by ambulance to a local hospital, which is 20 kilometers away and is small, or a tertiary hospital, which is 100 kilometers away and is larger? So the first question is, what is the tertiary hospital going to do that the local hospital can't? And if the local hospital can't perform a CT or X-ray, review and change meds, because remember, this is the problem is the antidepressant, can't stabilize the knee, which doesn't need an operation, and can't, after a couple of weeks, transfer to community rehab hospital, what kind of hospital is it? What kind of hospital What kind of doctors couldn't do that in 2025? And why has that situation been allowed to develop, that the hospital can't do those things? And then we have to think, what are the possible harms associated with transfer for this type of patient? Remember, this is an 80-year-old woman who is frail and has an 80-year-old husband who also has numerous chronic conditions. And transferring that woman 100 kilometers away, you now have disrupted relationships you have the patient on an overcrowded emergency department, possibly waiting on a trolley for admission. Less knowledge of the patients themselves, who may have been treated locally many times, and then disrupted relationships with community care. So will the people in the tertiary hospital know about the GP, know local community geriatric, psychiatry, rehab facilities where the patient could be transferred? And then you have obviously the extra economic travel burden on the 80-year-old husband. So, it's the problem is this one size fits all approach, which is not sensitive to context or changing populations, for example, an older and frailer case mix. And if you're interested, this is a really interesting paper I'd encourage you to find, which was published by a group from the Netherlands, which does a nice deep dive into exactly what emergency departments do beyond the high-tech kind of life-saving stuff that we see on TV dramas. And they divide up the activities of an emergency department into 4 what they call repertoires. So first of all, you have acute and complex care, which obviously needs, this stuff you see at the end here, standardized teamwork, high-tech facilities. Then they get into all the other less exciting stuff that we see in emergency departments, like uncertain diagnostics for, this type of patient, complicated patients, like the patients I just described. And then basic care for minor health issues as well, and dealing with all the other messy social and psychological problems that patients present with. And when you look at what is needed to deliver all this less exciting stuff, it starts to become obvious that volume and size aren't necessarily the answer. So what is it about volume and size, for example, that guarantees this stuff? Good communication and collaboration between a discharge coordinator and GP, rehab, residential care facilities close to a patient's home. In fact, I think you can make a good argument that volume and size might be negatively correlated with the ability to do that kind of stuff. And then I'm moving on to my final set of slides now. So I think the other thing you see in this area from kind of papers that aren't published by epidemiologists, more qualitative research, is this consistent concern about procedural injustice. So poor public engagement and a focus on informing by experts over listening. And obviously the role of experts in health policy has become hugely politicized since the pandemic, and more people interested in unpicking exactly what is meant by the things that experts say and where their authority comes from. I see this a lot in Ireland, diminishing the role of politicians and campaigners as populism. So in our area, for example, in Ireland, I come from a rural background, we have populist politicians who defend the small hospital and want to keep it open. I don't think it's populism necessarily for local politicians to campaign on behalf of retaining local services. That's what they're paid to do. I wouldn't expect them to do anything else. And I think sometimes we expect, as academics, I also work in a city, in a large university. Sometimes I think there seems to be an idea in health policy that we should just, come up with the right algorithm and then tell the politicians what to do. That doesn't seem like a healthy way to formulate policy. In fact, it seems like a recipe for disaffection and the rise of populism. I see cherry picking studies so that policies can be sold as evidence-based. So this idea of just picking the small number of volume outcome studies for single conditions like major trauma, as though everything should depend on those, and ignoring all the other conditions that go to emergency departments. I think that's cherry picking, and inferring whole population benefit from this small set of complex conditions. And then these ambiguous definitions of success and why we're doing things, ambiguous problem statements. So, like, let's say that the local politicians we're talking about, one of the pressures that come from policymakers is, if you don't do this, people will die. If you don't close down this hospital, people will die. So we're saving lives. That's the sales pitch. And then after the policy is evaluated, well, it didn't kill anyone. So what was the success definition at the beginning? And then a lack of candor about historical decisions that led to the impetus for centralization, especially the benign neglect of smaller units. Smaller units often are providing poorer quality of care, and it doesn't have to be that way. A lot of the time that has been due to long-term benign neglect that could have been dealt with differently. And obviously, I think you're all aware, because you're all working in a large academic medical center, that there are vested interests, that professional bodies, medical schools, large hospital groups have vested interests, not always financial, but they do have vested interests in making policy decisions, and a lack of accountability and a plan B in the case of failure. So all of this is what people now consider to be under the umbrella definition of procedural injustice. And then I think one of the problems in this area that I've observed is we are letting the tail wag the dog. So first of all, what is the reality of emergency care? How many patients attending EDs require high-tech, life-saving care immediately? And why are the requirements of these rare conditions, major trauma, stroke, MI, driving system design? Why is everything based around those conditions when that isn't the volume that we see? And then, a failure to account for this, I'm sure you're all aware of the game Jenga, this idea of, if you remove certain capabilities like acute surgery and intensive care from a hospital, now the other 95% of activity can't be safely provided. So just doing that alone is hugely damaging to what hospitals can do. So, shouldn't we be starting with the 95% of conditions that don't require life-saving care? And obviously other interests should not drive the process. Those other tails on the dog, like medical school training needs, the financial motives of large academic health organizations, staff location preferences, and all these other trends that we see in professional bodies like subspecialization. Those shouldn't be the things that are driving reconfiguration. But the ultimate thing, we can all agree, this might sound pious, but I don't think anyone would disagree. The ultimate thing that should drive reconfiguration is population need and population benefit. Is it going to benefit the population who is served by these facilities? So that leads me on to these important questions to ask when framing a policy dialogue. Who is the policy about? Who is supposed to benefit, i.e. which patients, and who is likely to be harmed? Do we have any plans to help people who are likely to get harmed? And I don't just mean in terms of clinical outcomes, I also mean financially. Are there any professional groups or providers that might benefit? How is the new policy supposed to work? What are the mechanisms of both effectiveness and harm for all the patients who are impacted by the new policy? So if you're going to close down a rural emergency department, how is that supposed to benefit the 80-year-old woman who is on antidepressants that I described earlier? Tell me about the mechanism that's supposed to benefit her. What is the role of evidence here? And is evidence all we need, or do values play a role? And if so, whose values? And then my final slide is whose values should count. Now, the Institute of Medicine has come up with this 6 dimensions of quality. Other people have other definitions, but I think we can all agree that patient-centeredness, equity, timeliness, safety, effectiveness, and efficiency are important dimensions of quality in healthcare. And there are trade-offs between them. So for example, when you make care safer, you may make care less patient-centered, you may make it less timely, or you may make it less equitable. Where does the authority to prioritize one dimension over another come from, and who gets to decide? And this is the quote I'll leave you with, which came from a really nice paper we published a couple of years back about the pandemic, published from New Zealand. And it's a piece of qualitative research. And you can see here, it's a clinician saying, what this paper was about, the experience of clinicians in providing end-of-life care in facilities in New Zealand during the pandemic. And you can see here this quote: if someone is being nursed in a side room, but you know what really is the risk? What is the risk to people coming in, agreeing to wear their PPE, meaning relatives, and masks through a corridor, and then sitting in a side room with the door shut? It did seem there was a bit of a lack of common sense, that we were actually just sort of sacrificing a group of people for the possibility of what might be occurring with another group. And throughout the pandemic, I think we started to become aware of value decisions that were being made under the surface, prioritizing one dimension, ostensibly safety in this context, over another, without open discussion and public debate about the trade-offs between these values. And then finally, this is an editorial I wrote. If you want to read more about the arguments I've made today, with Luella Vaughan, who is a generalist emergency physician who works in a large London hospital, about reconfiguring emergency and acute services, and arguing that it's time to pause and reflect and maybe come up with a different policy trajectory. All right, thank you very much for listening. Thank you.
Thank you, Professor Browne, for those comments. Really thought-provoking, maybe a little bit of anxiety-inducing, thinking about trajectories, especially at the whole population level. Remind attendees for the webinar that we have an opportunity for some Q&A with Professor Browne right now for the whole group. So if you have questions, please put them in the Q&A. But maybe I'll go ahead and kick us off. I think you made a really compelling argument for the both the limited body of evidence at whole population level, as well as what that evidence does show. For those of us who are health services researchers, perhaps not coming from epidemiology, I was wondering if you could sort of share some insights about sort of the reasons why additional whole population work hasn't been done, or some strategies that investigators could consider to help sort of look at the whole system as opposed to a single condition.
Okay, great question. I can give you two answers to that. So the first thing is, why aren't more reconfiguration initiatives whole population? Like, why aren't they taking into account this whole population group? Because it's hard, and because care is fractured. Even in nationalized systems like our own, just getting two hospitals to talk to each other and agree, you do those people and we'll do those people, is almost impossible most of the time. It's very, very hard to get people to just agree. Like in my locality, Cork is here, down there is Kerry, okay? 150 kilometers down there is Kerry. They're all supposed to be working within the same hospital group. To get the emergency department doctors to talk to the people down in Kerry is hard. Why? Because they're so busy and they've got so many other things to do that I think the natural response is, well, just let them get on with it. Like, why do we have to keep talking all the time? Now, I think over time, people are starting to realize that you do need these, whole system management processes and more bypass protocols and more of an understanding about how the system as a whole is supposed to work together, but it's not easy to do. Why don't epidemiologists do more whole population analyses? I'm going to be unfair to some of my statistical colleagues here. I think it's naivety. I think, and I'm saying this as a person who was very naive in the past. I think a lot of the people who publish these papers are sitting in their offices. They want to get access to secondary data sets, and they just want to dump it all into R and start doing the coding. And when someone comes into the room and says, do you actually know what the inside of an emergency department looks like, or how these facilities operate together, or even where they are? Do you even understand where they are? Then I think a lot of people just say, that's not my job. My job is just to crunch the numbers. And of course, what's easier than just, taking a facility level covariate, or sorry, facility level, independent variable like size, and sticking it in a multi-level model and coming up with some nice coefficients and getting it published in the Journal of Clinical Epidemiology. That's the academic career, unfortunately. And I do think it has contaminated the area. I would say one other thing, which is, where do these people work? Where do these, clinical epidemiologists, health service, they work at the Cleveland, at the Cleveland facility. They work at Cork. I used to work for the London School of Hygiene and Tropical Medicine. These big urban facilities, which coincidentally happen to benefit from a lot of the analyses that are being pushed through. So I think, like where the clinicians I see are asking the wrong questions, or they're often asking questions which coincide with the things that they would like to happen in the world. So there are very different ways of asking these questions. You can just say, do people who go to big hospitals have better outcomes? That's one way of asking the question. Or you could say, do counties that are served by smaller hospitals have better outcomes than counties that don't have smaller hospitals? That's a completely different question, but that would never occur to many people, because they'd be like, that's not an interesting to me because I don't work in a smaller hospital. And sorry, I'm going on, but one last thing I'll say is, who is sitting at the table when these decisions are made? It's very unlikely to be leaders from smaller peripheral rural hospitals. And, like, as we all know, if, if you're not in the room when lunch is served, then you are the lunch, unfortunately.
So I have a question. Thanks for the great presentation. Lots of food for thought. And, a lot of the data, or all the data that you presented today, is clearly from high-income countries with very robust or somewhat robust healthcare infrastructure. How does this translate to resource-constrained settings? And, and personally, my work is in some of the very remote areas of Africa, and we had to think about this concept, and you did mention about context, I guess. So, but I wanted to know first is there any evidence or anything we know from resource constrained settings? And second is how it may look different in those contexts where there's a fragile healthcare infrastructure.
I'm not really familiar with that. And I think one of the frailties of our journal is that we haven't published that much. There isn't that much research done, unfortunately. There is a fairly decent evidence base emerging on the quality of surgical care in sub-Saharan Africa. Obviously, most of that is delivered in larger facilities. I think what you see mostly in Africa, at least I'm familiar with some of that literature, is what people are exploring. Reconfiguration isn't really the question. The question is, how can we leverage in other tech like AI and remote care to improve the quality of care? But it doesn't seem to be a big issue at the moment there. I mean, that issue about remote care and tech, AI and so on, is often preferred as a solution in developed countries as well, like some kind of magic bullet that will come along. And I don't discourage that idea, but I think we should be doing everything we can to solve these problems, but let's not expect that any one thing is going to solve the big problem, which is the massive rise in demand we see from older, frailer people.
Thanks.
Got one final question from the group before we transition. So instead of thinking about single condition kind of cases for reorganization or centralization, are you aware of or can point to any literature that looks at kind of impact by function, for example, differences in opioid prescription for pain between larger urban and smaller rural EDs before and after centralization?
No, and that's a really good idea. The work that I have used and the Danish people have used came out of Sheffield in the United Kingdom, where a guy called John Nichol did this consensus work and said, if we were going to judge an emergency department, which conditions would we use to judge them? And stroke and major trauma and all that stuff is in there. But then all this other stuff is in there as well. And that's the life-saving stuff. So it's still life-saving. They're not looking at Mickey Mouse stuff. They're looking at important stuff, but it's all the other stuff that that doesn't get talked about. And what's really interesting is that it's those conditions, it's the non-stroke, non-trauma, non-heart attack conditions where reconfiguration really seems to do the damage. And I think I like the idea of unpicking what's going wrong with those conditions when we impose centralization. And I can send you the list of those 16 conditions if you want. And I think, obviously, opioid is not one of them, but I think that does raise the questions about, what's really happening on these other, for these other conditions.
Wonderful. Well, with that, we're going to wrap up the public portion of the session. Thank you so much, Professor Browne, for your time. We're going to ask the attendees to go ahead and exit, and then we'll transition to the meet and greet.
Brilliant. Thank you. So is everybody here clinical?
John, do you mind, stopping your presentation so that we can all be on the screen? Stop sharing
Yes.
your screen.
I was just trying to do that and I couldn't.